The couple of things I want to just stress: stage 4 melanoma and liver metastases that we talked about. I mean, that is you might as well get the death certificate out. I mean, that is. It doesn't get any more serious than that, does it, in terms of cancer? These are remarkably serious terminal stages of cancer. So the response that you got in those conditions is astounding.
Yeah, obviously not in everybody. Nothing was.
No, but the fact that you saw a response is astounding.
That we were seeing benefits you would normally have expected with approved treatments. Put it that way. And with zero side effects apart from. It affects dreams and sleeping a little bit initially, but 95% of people it completely disappears there. And then any other side effects, very idiosyncratic depending on what they have. But overall, I'm not worried about side effects with it, except make sure they don't take codeine, because you get some interaction there going on which they don't feel well. Apart from that,
right.
So
this second bit, the TLR. So that, let me see if I've got this right. This is the toll-like receptor.
Yes.
And these are receptors on white blood cells.
Yes, they are on immune cells. A variety, white cells, lymphocytes, and other cells. Basically, it's immunological cells.
Yeah, and normally they will be recognizing a foreign bacteria or virus.
Yes, exactly. They're the first line, part of this innate immune response.
Yeah. And the low dose naltrexone is binding onto this receptor, which would normally identify the presence of a bacteria or virus, this toll-like receptor 9. And that was stimulating the cell to produce this IL-6, and the IL is the interleukin, going between leukocytes, between the white blood cells. Yeah. It's what we would call a cytokine.
Yes.
But my understanding is that this IL-6, this interleukin-6, is the most potent pro-inflammatory cytokine that's going to stimulate ordinary cells to become malignant. Am I roughly on the right? Is that roughly correct?
Well, it certainly if they are already turned malignant, it fuels them.
Oh, right.
Yeah, then that's the way I interpret it.
Right, got it.
And why I think that this is such an important property of this drug. And then, as you know, we found other mechanisms that gave it anti-cancer activity. The most important, I believe, from a practical point of view, is it sensitized all the tumor cells that we have growing in the laboratory. Doesn't matter where they came from, they're sensitized so they die much quicker with chemotherapy, to the point where we could have the cells there, you give chemotherapy, nothing much happens, you get a dose, then they start dying. But if you gave them low dose naltrexone and then the chemotherapy, they start dying very quickly, and you can completely have the same effect with half the dose of chemotherapy. Now, from my point of view as an oncologist, if I could reduce the dose of chemotherapy in all my patients, knowing that it would not reduce the efficacy, it would be unbelievably helpful, because all the side effects are in the top 50%. And it would actually, it gives the confidence, and I've had the confidence to give people start at 75% of the dose, rapidly go to 50% of chemotherapy, and have the same expected response without the side effects. Now, most people with chemotherapy, they're a big burden on the NHS as the side effects. I mean, they're just not horrible. They have to be treated with all these various things. And especially those drugs that hit the marrow. I mean, it's just an incredible amount of care. So here you have a drug that, one, switches off the cancer growth factor, two, sensitizes the cancer to standard treatments, chemotherapy. We've shown it's the same for radiotherapy, etc. So it's really useful. And everyone goes, oh, that's interesting, but it's not been approved. Yes, this is a completely correct argument. But, you know, only you people are actually in the position to do something about it. But who's going to pay for it? Now, it is the attitude now that all trials seem to be only done if Big Pharma's paying for them. So basically, Big Pharma controls the strings. And it doesn't like things like this that are very useful and things, because they would reduce the demand for products down the line. And it's very interesting that the interleukin 6, that, if it is so important, then surely Big Pharma would have targeted. And the answer is yes, they have. If you find to have too much interleukin 6 in your tumour after you've tried all the first lines, then they will sell you a monoclonal antibody to it at tens of thousands a month, of course. Yeah. Whereas my point is, we have something here that will make that unnecessary if you give it in low doses early. The earlier you give this, the better. Remember,
this is what big pharma does. It takes away the broad treatments, what you might call the health improving treatments.
Yes.
The treatments that can affect a wide range of potential oncogenic and cancer promoting pathways, and it goes to the far end of a bit of minutiae. And it says, well, there's a particular molecule here that interacts with this particular receptor here. Let's block this very specific interleukin 6 activity with a very specific chemical that's patentable for 15 years. Whereas you could do it with low dose naltrexone. It's just so typical of big pharma. More and more precise, what I would call clever clogs pharmacology. And it is clever, there's no question about it, going for a really, really specific molecule. Whereas why not just improve the whole thing? It's just, drives you mad.
This is really what I've been fighting for, is that if you're going to go, and I've seen it with so many patients, I mean, I'm just an old oncology doctor, I've seen it, they go in, they get offered these horrendous treatments, and they're not well. They're not well. We were very early on. We showed that people who didn't respond early had low vitamin D, and you've got to. It is a waste of time treating cancer patients if they got low vitamin D. Complete waste of time. So that's the first thing. The second thing was realizing that they needed their innate immune system boosted, and that's where the IMM came in, the heat-killed mycobacteria, because everybody with cancer, his innate immune system is suppressed, and you need to rise that up. The importance of the low-dose naltrexone is that cancer is fueled by chronic inflammation, and I've co-authored books and edited books just on that, inflammation and cancer, chronic inflammation and cancer. So here you have a unique anti-inflammatory which is actually damping down cells which produce cancer growth factors. I mean, if you were to design what you wanted, you wouldn't expect it to come up. It's already there. It's just incredible. So with all my patients now, I want them on vitamin D, increase their innate immune response. Won't go into the details on the IMM, etc. on this talk. But you want to damp down that inflammation, and I have been doing that with suggesting they take aspirin, soluble aspirin, and there's a lot of evidence that helps, particularly colorectal and many other things. But I think naltrexone's, even the low dose naltrexone's, even more cancer specific with damping down basically the fuel. I mean, you're basically with this shutting off the fuel the cancer needs to grow. So to me, doing those three things first, then you decide what specific treatment do they need. Oh, they got melanoma, they might need these new immunotherapies, the checkpoint inhibitors. And yes, we've already shown, and my colleagues published at ASCO, that with IMM, the 101, if you prime with that, you double your response rate to these drugs without any increase in toxicity.
Everyone with cancer should have the D3 optimized, the D3 levels optimized to 40 or 50.
No, over 100. Over 100.
Sorry, in English. 40 to 50 nanograms per mil, but well over 100 nanomoles per litre.
Yes, absolutely. Yeah.
They should have the D3. They should have the low dose naltrexone because it's no side effects. And the IMM 101, the heat-killed mycobacterium.
Or something along those lines.
Which stimulates the immune system, Yeah, and all of those are completely safe to do.
Yes, indeed. And as I said, I in hindsight, I believe these things should be started on everybody with cancer, whatever cancer they have got, in order to make the other treatments work better and have less side effects, because certainly with the chemo you can reduce the dose, and that is a holy grail, to have non-toxic chemotherapy. You speak to anybody who's been through grueling chemotherapy, and I get to meet people who've just said, I had 3 courses, I'm not having any more. Even if you tell me I'm not having any more, I want to know what the alternatives are.
I've had patients that have said they've chosen death rather than go through another cycle of chemo.
Yes, yeah.
It is horrible. And if you half the dose of chemotherapeutic agents, would you roughly half the side effects as well? Is that about how it works?
All the side effects are in the top half.
Oh, I see.
This is my bit. I mean, when you get down to 50% of a lot of these agents, the side effect profile is really mild compared to the top half. And this is even accepted. They will give you 100%, and if you get bad side effects, they will reduce it by 10%.
Yeah.
But the side effects, like a neuropathy, for instance, is already set in motion. It's not going to achieve that much. So to be able to set the doses at a lower level and not kick in some of these long-term side effects would be just incredibly useful. I mean, if I had the cancer, would I take it? Yeah, I would go straight on the low-dose naltrexone before I knew all the investigations had staged.
Yeah,
that's how important I think it is.
So these 3, what we might call prerequisites or universal adjuncts, the vitamin D, the Mycobacterium challenge, the Mycobacterium vaccae, the IMM101, and the naltrexone. Is there any cancer therapies with which you could get interactive adverse reactions from giving those 3 preeminent interventions?
No, they only enhance. I mean, we have done so much work and published an IMN, and a lot of other people have too, with different cancer types. Vaccae was used with lung cancer, mesothelioma, and my colleagues and I did it with melanoma and colorectal cancer and pancreas, and so it's the same across the board. They seem to get a better outcome whether they're using chemotherapy or the immunotherapy. I don't see any negative association. The only negative association with when on low-dose naltrexone, beware the opiates because of this clash over the opiate receptor.
Yeah. All it means is you'd have to give a higher dose of opiates for the same analgesic effect, doesn't it?
Well, yes. Or this is the only thing that we're just very careful about.
Yeah.
But
right.
I've had patients on low dose naltrexone who then had trauma, and they've forgotten what I told them about opiates, and they go in and get a big slug of morphine or something, and they continue on that, and they've had no side effects. So what I'm doing is super caution from speculation.
Yeah,
actually, in practice, there was none. And when I thought about this, is when I don't believe the low-dose naltrexone is blocking the opiate receptors. It's just changing expression. It's blocking the inflammatory pathways. At the high dose, you put in a very high dose of morphine, it floods the opiate receptors. The low-dose naltrexone is not going to compete with it. So I'm just giving an example. You can speculate and be careful that, but actually, so many people have told me, they've had morphine and they never had any adverse reaction to it.
No, it's an abundance of caution. So vitamin D, D3, dirt cheap. Naltrexone, they can make it by the ton because it's off license. I mean, you can make it for essentially nothing. The IMM 101, how often would you have to give that? It's an intradermal injection, isn't it?
Yeah, well, it is an intradermal injection, and as I mentioned, I was very saddened to hear the company literally run out of money. It's very unusual for a company to run out of money while doing trials. They usually run out of money because big trials failed. And when I've gone through every trial they've been involved with, everyone's been positive. No side effects whatsoever. And I trace it all back basically to the lockdown, because the money was on the table then. And then it was going to be released. The second lockdown did it. The people kind of walked away, lost interest. And, I think people probably do realise how much damage the lockdown has done to everybody and everything and the economy and everything. And I think the people who pushed it through and didn't listen to what many of us said, you know, this it will be an absolute disaster. You don't need to do it for an airborne disease. It's completely utter mad. I think they need to be held to account, because all the answers I've heard at the inquiries and this, that, they were nonsense. Absolute nonsense.